guys. Today we're going to be talking about Down syndrome for our special populations presentation. So I'm going to give a little introduction on some characteristics of Down syndrome, and first I want to talk about what it is. So Down syndrome is a congenital genetic condition. So this is something that a child or a baby is going to have at birth. It's not going to be something that later on when they're 5 they just acquire it. So it is congenital. It is caused by a defect to chromosome 21. So they might have an extra copy, they might have more of it than they need. And it is the most common genetic chromosomal disorder, and is also the most common cause of learning disabilities in children. So it's most likely not inherited, but there are some risk factors that can kind of be red flags for Down syndrome, and one of the significant ones is the older the mother's age is when she gets pregnant, there might be an increased risk for Down syndrome. So incidence and prevalence for Down syndrome. So again, this is a congenital disorder. So this is diagnosed at birth and sometimes before birth, because doctors can usually see some things before the baby even is born. But about 6,000 babies a year are born with Down syndrome. So that equals out to about 1 in 700 a year. And babies born with Down syndrome have increased 30% between 1979 and 2003. So there was an increase there. I don't know if it was maybe women being older and having children or what. And also prevalence of Down syndrome goes up as a mother's age increases. Like I previously talked about, it is shown that older women have a more likely chance to have a child with Down syndrome. And some other factors are if you've had a child with Down syndrome before, then you might be more likely to have another child with Down syndrome the next time around. Some physical characteristics, now that we've talked about what Down syndrome is and some incidence and prevalence on that. Some things to look for physically for someone with Down syndrome. You might see a smaller head, maybe more flat face compared to an atypical developing child, maybe a shorter neck. They tend to protrude their tongue out of their mouths a little more at rest. They might have more poor muscle tone. Their eyes are slightly upward facing in the way that they're set, and also shorter in height. Along with Down syndrome comes some health complications that they're more at risk for. So that might be hearing loss. That's quite prevalent in children with Down syndrome. Sleep apnea, ear infections are very prevalent, along with heart defects, gastrointestinal issues, and obesity is also seen and is more increased likelihood in individuals with Down syndrome. So those could be some things where they're not automatically going to have them because they have Down syndrome, but you might be on the lookout for those things and maybe just some signs so that you know to go and get your child checked out if they do have Down syndrome. And the last slide I'm going to be going over today is about the cognitive characteristics of individuals with Down syndrome. So most children with Down syndrome are going to have cognitive impairments. Their language is going to be delayed. It could be anywhere from mild to moderate, some may be more severe than others. And short and long-term memory are also affected.
Individuals with Down syndrome generally follow a consistent language profile. In many cases, their receptive language is stronger than their expressive language. Vocabulary is stronger than syntax and phonology, and there are often some pragmatic difficulties. Hearing loss is directly correlated with language development. 2/3 of children with Down syndrome have conductive hearing loss, sensory neural hearing loss, or a combination of both, ranging from mild to profound. Otitis media is a common contributor to conductive hearing loss. It is thought that children with Down syndrome are more susceptible to otitis media, potentially because of their narrow auditory canal and craniofacial differences. One study found that otitis media occurs in 96% of children with Down syndrome. Hearing loss can lead to difficulties with comprehension of grammatical morphemes and vocabulary. The prelingual and early nonverbal communication skills of infants with Down syndrome may look very similar to other typically developing infants. Frequency and variety of consonants, as well as vowel sounds produced, are found to be similar in infants with Down syndrome as other typically developing infants. The onset of canonical babbling may be delayed by as much as 2 months. Gesture use may look similar, but the kinds of gestures may look different. It's found that infants with Down syndrome produce fewer nonverbal requests. Speech production in those with Down syndrome is often characterized by limited intelligibility compared to peers. Oral motor skills are limited, possibly due to differences in oral structure and function, such as the small oral cavity and large tongue with a narrow, high-arched plate. Phonological errors are common, in addition to childhood apraxia of speech and dysarthria. Expressive language is often a major challenge for those with Down syndrome. In early years, typically developing infants usually acquire their first words around the age of 1. In those with Down syndrome, this milestone is often delayed. Individuals with Down syndrome typically produce shorter, less complex utterances than those of their same mental age peers. They often struggle with grammatical morphemes, such as the production of tense and non-tense articles. Some researchers actually suggest that poor intelligibility may be directly related to expressive language difficulties. Communicating in mainly key words may be a more successful strategy, making simple syntax an adaptive process. Receptive language is usually far superior to expressive language. Those with Down syndrome are able to understand much more than they can express. Receptive vocabulary and oral language comprehension appear to be similar to those typically developing same mental age peers. Many children with Down syndrome have difficulty understanding abstract concepts and complex syntax. Along with receptive language, social language can be considered a relative strength. Those with Down syndrome are often characterized as being overly social, engaging, and affectionate. They're able to form positive peer relationships in a way similar to their typically developing peers. Similar performance is noted on tasks of turn-taking and topic maintenance. That being said, some social skills are impaired. Because of their difficulties with complex syntax, individuals with Down syndrome struggle to have meaningful contributions to conversations. 15% of those with Down syndrome meet the criteria to be diagnosed with an autism spectrum disorder. Impairments of receptive and expressive language are often thought to extend to reading and writing skills. Tasks involving word identification, such as whole word reading, tend to be a strength, partly due to their visual processing skills. Phonological processes, such as sounding out words, can be difficult because of deficits in phonological awareness.
The PLS-5 is the first language assessment chosen for assessing language in children with Down syndrome. PLS-5 stands for Preschool Language Skills 5th edition. It assesses the total language, auditory comprehension, expressive communication, standard scores, growth skills, percentage ranks, and language age equivalence. This assessment is made for children from ages birth to 7 years 11 months. The PLS-5 can take up to 45 to 60 minutes to complete. If a child has a hard time focusing on a singular task, this may be difficult to give. Some adjustments may need to be made, such as focusing on certain parts of the assessment you may find most important to assess or where you feel areas of the child is struggling in, or cutting the assessment into time increments and allowing the child to play in between each, or needing to complete it across multiple sessions may also be a helpful way to make the assessment more doable. There are different benefits to using the PLS-5. One benefit being that children with Down syndrome normally are delayed in expressive speech, and this evaluation allows kids to point, imitate, or gesture for their answers instead of having to communicate verbally. Also, this assessment can assess receptive and expressive language skills if needed, and the assessment is more like playtime than it is a test. Another language assessment you can use with children with Down syndrome is the CEL-5. CEL-5 stands for Clinical Evaluation of Language Fundamentals, the 5th edition. This assessment can score the core language scores, receptive language, expressive language, language structure, and language content standard scores, percentile ranks, growth scale values, and age equivalents. The age range for this evaluation is from age 5 years old all the way to age 21 years, 11 months. The CEL-5 evaluation takes about 30 minutes to complete. This is beneficial due to the shorter amount of time that you have to keep the child's attention. There are limitations that come with giving the CEL-5. The biggest limitation is the child needs to be able to verbally answer questions. As we know, children with Down syndrome are normally delayed in language skills and in some cases nonverbal. This eval may be better used for the older population of children with Down syndrome due to the need to answer verbally in order to complete this evaluation.
The Test of Language Development Primary 5th Edition is a norm-reference expressive and receptive language assessment that assesses oral language strengths and weaknesses for children ages 4 to 8. The TOLD P5 includes 6 subtests. The results of the subtests can be combined to compose scores for the major dimension of language. Expressive language skills can be more challenging for children with Down syndrome than receptive skills. The TOLD P5 includes extensive studies for validity. These studies indicate that the test internal structure is sound, and results can be used for different subgroups as well as general population. The assessment administration time is between 30 to 60 minutes. Limitations would include administration time, and assessment recommendations for children with Down syndrome include having the child interact with peers or teachers in the classroom. Phonological awareness intervention is an approach used for young school-aged children as an approach for reading and oral language for expressive phonological difficulties. Research conducted by PRAW focused on identifying phonological awareness intervention for individuals with Down syndrome. It has been recommended that standard treatment protocols be adapted to teach phonological awareness skills for children with Down syndrome. Children with Down syndrome can benefit from small groups, intensive and systematic phonological awareness intervention to progress their development of phonological awareness skills. Children learn to segment spoken words into phonemes, learn to match sounds to letters. Learning phonemes will allow phoneme blending and phoneme segmentation. Phonological awareness intervention modifications would include implementation of visual supports using pictures, limiting the number of phonemes, teaching strategies using scaffolding instructions, encouraging students to feel, look, and listen to the sounds and words using multisensory methods. As the study by PRAW indicated, through observation, students gain exposure to phonological awareness instructions in group sessions. Individuals with Down syndrome actively participate, engaging in intervention that involves turn-taking with peers. Intervention activities would include rhyming bingo, phoneme identifying, and phoneme segmentation.
Language intervention for individuals with Down syndrome primarily focuses on improving functional communication for academic, social, and vocational areas. It is important to develop an individualized treatment approach that targets communication needs and current levels of functioning. The following principles should be included in language intervention: individual characteristics, syndromic characteristics, language components, family, school, and community context for promoting generalization, and developmental perspectives. A variety of language deficits are present amongst children with Down syndrome. However, expressive vocabulary, syntax in both expressive and receptive language, and pragmatic deficits are common for the Down syndrome population. The following strategies can be used for enhancing learning skills and promoting generalization in children with Down syndrome. Conversational recasting is one of the methods used for helping children develop more complex sentence structures. For example, the child's utterance is reshaped by the clinician to help expand grammatical components. Expanding vocabulary can also be a beneficial learning strategy for increasing semantic skills and spoken utterances. Topic initiation intervention can also be beneficial to address pragmatic skills due to initiating topics being an area of weakness for individuals with Down syndrome. Incorporating the client's topic and materials of interest are also recommended, as well as using open-ended question and additional processing time. Speech intervention for children with Down syndrome typically target the following areas: speech intelligibility, phonological processes and sound errors, reduction of syllable structure processes, rate of speech, voice quality, and oral motor exercises. It is important to assess all areas that contribute to speech production, such as pitch, rate, oral motor structures and functions, as well as phonological processes, to determine the deficit areas affecting intelligibility. Based off the common speech profile of individuals with Down syndrome mentioned in the previous slides, interventions that focus on syllable structure processes and phonological processes may improve overall intelligibility. The cycles approach can be beneficial in targeting unintelligible speech due to the certain phonological processes targeted during specific cycles or time periods. Speech production can be also addressed through oral motor exercises and activities to increase coordination and strength of articulatory muscles.
Other professionals that can work with children with Down syndrome are occupational therapists. OTs work with children with Down syndrome to help them improve their participation in everyday activities and independence in these activities, and this can be lifelong. The types of activities OTs focus on are on a person's occupations, which include sleep, hygiene, dressing, cooking, self-feeding, employment, transportation, attending school, and toileting. Other areas that an OT can provide support are in sensory processing challenges. This is especially important because during a speech therapy session, these sensory behaviors or challenges can be a barrier for the child to be focused and learn the or do the targets that are meant to work on for that day. So other ones are feeding challenges, fine motor, gross motor, and coordination skills. And like we talked about before, activities of daily living. Also school-based support, employment skills, healthy relationship and sexuality, social skills, mental wellness support, assistive technology, and adaptive equipment. And the ways that the OT and the SLP can collaborate are by consulting to consider client-specific goals and to ensure that they agree on the child's therapy plan. Through this process, they can decide to co-treat with the SLP, integrating certain occupational therapy activities into their sessions with the child and vice versa. Occupational therapists often incorporate speech-language therapists in their practice during requesting activities, for example, by using words or phrases that have been targeted in the speech therapy sessions, or even using communication boards or AAC devices. SLPs and OTs can help create a comprehensive approach to the child's care during the development of IEPs as well. And this can be seen more in schools. Another professional is a physical therapist. PTs work with children with Down syndrome to help them develop gross motor skills. Children with Down syndrome can present physical characteristics such as hypotonia, ligamentous laxity, and decreased strength. Therefore, PTs can focus their intervention in helping them develop good posture, proper foot alignment, and efficient walking pattern, and a physical foundation for exercise throughout life. Ways that SLPs and PTs can collaborate are by supporting the common goals of optimizing recovery. While the PT works on appropriate postures, the SLP can benefit from this intervention if a patient is having feeding or swallowing problems. Therefore, both disciplines can work together to create goals that will be of greater benefit for the patient.